इसमें वॉल्यूम नहीं आ रहा क्या इसके कोई? इसमें वॉल्यूम नहीं आ रहा क्या? आ रहा है, लैग रहता है इसमें। ठीक है, so now I have to copy this one. Right. हेलो, हाँ हाँ, हेलो। एक बार प्रति के हॉस्पिटल से आ रहे थे डॉक्टर। हेलो, हाँ बताइए। उसकी बात क्या हुआ? इसमें वॉल्यूम नहीं आ रहा क्या? लैग रहता है इसमें। ठीक है, so now I have to आगे जूम का लिंक तुम्हें चाहिए होगा है? अच्छा अच्छा, लैग रहता है। रजिस्ट्रेशन 80 के करीब हो। $325 वाला तुम्हारा है? देखो आ गया होगा इसको। तो मिटेंडी में आ गए हैं। मिटेंडी को चैट पहुंच जाता है। ये यूट्यूब लिंक है। वो लिंक हम शेयर कर देते हैं, तो आप लोग कोई पूछेगा तो उसमें कर देंगे।
फेसबुक पे नहीं डालेंगे,
अभी नहीं, अब डालेंगे। तो उसके थ्रू आप ले लोगे हैं?
लिंक
तो ये अभी आपके पास नहीं है ये वाला लिंक। So good afternoon, everybody. Today we're going to discuss about a very, very important and a relevant topic of iTurner syndrome, which is extremely important from a clinical perspective about what's happening in terms of Turner syndrome. And we're going to talk about the entirety of the disease, starting from genetics to clinical parameters, how we have had changes in terms of pathophysiology, evaluation, assessment, and management. And this is one condition which is very common, but unfortunately, there are a lot of issues which cause confusions in that regards. So this is going to be an interesting talk, and we'll have a lot of cases to discuss as well towards the end of it. So we'll start off directly with regards to the situation. So this was one case, 10-year-old girl with growth failure who presented to a pediatrician basically with growth failure and was found to be short and was found to have a weight also which was compromised. And further evaluation showed a TSH level which was basically slightly high. She was started on eltroxin, but there was no clinical response. And subsequent to that was referred with complaints of growth concern. Now, this is a case which clearly we have got significant short stature. The TSH is high and you think the diagnosis is made. But what is important to understand is that there are many other conditions which may actually attribute to hypothyroidism. So we have seen cases who have celiac disease who have just found to have hypothyroidism and further workup was not done. This happened to be a Turner syndrome who actually had very subtle features of Turner syndrome. So very importantly, while you are diagnosing hypothyroidism, you have to be a bit more cautious in this turn out to actually be a Turner syndrome. So any short girl, always consider the possibility of Turner syndrome because there are huge implications in terms of evaluation and management which are there. 12-year-old girl with growth failure, again height is compromised, weight is less, there is no breast development, no pubertal development. Typical features, brachymetacarpia and webbing. This is a classical case, and you will say if you see this case, there is basically webbing of neck, there's wide carrying angles, shield chest, and you will say this is Turner syndrome without any confusion. Now, what happened was that FSH was found to be elevated and growth hormone was started, but unfortunately, this girl did not take growth hormone. That is one aspect because there are a lot of cost issues as well. But she came back 3 years later to us. So this was evaluation done by another center. And when she came back to us, there was an abdominal lump. And this happened to be a Turner syndrome with a Y cell line. Now, we all know that if there is a Y cell line, there is an 8 to 10% chance of having a gonadoblastoma, which may further develop into a malignancy. So in this case, while a diagnosis was established, which is okay, but we did not carry it forward with karyotype. So there are issues in terms of not only diagnosis, but also evaluation, which become significantly important in that perspective to identify in that regards. So Turner syndrome is one of the most common sex chromosome aneuploidies. In fact, one of the most common in girls, 1 in 2,500. It has got a wide spectrum of presentation, and Pratik will talk about how when we should consider that situation. It is often delayed at missed, even in the developed nations. The average age of diagnosis is around 8-9 years, which is pretty late. In our country, it will be probably like 12 years, so it is quite late. And there are lifelong implications with regards to the heart, the kidney, the eyes, the ears, the autoimmunity. And Dr. Naveen is going to talk about that in detail. So this is something which we're going to discuss about. And very importantly, it is the only monosomy which is compatible with life. And this is an interesting phenomenon which I'll discuss when I talk about genetics as to how this is one condition which a person can survive in that perspective. Importantly, 99% of conceptors who have got X0 karyotype will actually not be able to make it. They will actually die in utero. So it's like a 1 in 100. Those who have come out have really struggled a lot. So this is a confusing picture as to why we have got this monosomy which is going on. There are huge implications, and we'll discuss about that later on. So this iTurner will focus on different aspects of Turner syndrome. You can have a look at our website, Learning.Grow Society, which has got a lot of information about that. This webinar will also be posted there in the webinar section. So you can go and have a look subsequently on individual videos. From there, you can have a look at our masterclass in pediatric endocrinology, which covers the entirety of pediatric endocrinology, now approximately 100 modules using a number of factors. You've got a postgraduate course also, which is a 3-year course for postgraduates. And we've got the books which are available, the MedEClasses books. And just this week, we have published the Indian Journal of Pediatrics, Practical Pediatric Endocrinology book, which is a book which is basically there for guidance with regards to specific management on 30 pediatric endocrine disorders. And there's a MedEClasses application available on endocrinology and pediatrics, both in the iOS and Android, which provides very easy way of assessing and managing these disorders. So iTurner syndrome would be a program which will basically try to cover a number of factors. We'll start off with the basics, basically how the genetics works, how we evaluate and how it has implications. Then Dr. Pratik will talk about pointers and criteria, followed by a bit of assessment, which Naveen will carry forward. Then I'll talk a bit again about growth hormone and cardiac issue. Then Dr. Sayan will discuss about what's latest with regards to puberty. And then we have got a big number of cases which will really help us interact. This program is supported by Pfizer India. So we like to thank the supporters of this, the sponsors of this program who have helped us bring this into light. So what we'll do now is that we'll go back to the very basics, because genetics is the crux of it, because all the things that we're talking about, the manifestation, the treatment, ultimately have a genetic basis. So we need to understand how all these things happen. So if you look at the chromosomes and you look at the karyotype, which all of us have done many times, there is of course a difference between a normal male and a normal female karyotype, and the basic difference is 2X versus XY. Now, if you see just the pictorial representation, you see that the X is much more heavier than the Y. So women are carrying a lot more burden than men, even from a karyotype perspective, if you look at it. So therefore, in a way, there are a number of genes which may be double in the woman as compared to men. So what's going to happen? How are you going to balance that out? And that becomes important. We know how a single gene can cause a huge problem. If you have so much more genetic material, what really happens becomes important. So there is a discrepancy between the two. There are double doses of genes, and therefore there is a need to balance to allow this outcome. And this balancing process is long known as the process of lionization, in which these sections which are there in the X chromosome, which are not in the Y chromosome, are inactivated. So if you look at a typical chromosome, the X chromosome has got a long arm, the XQ, which is basically then linked by a centromere to the short arm, the petit arm, the P arm, and the Y chromosome is much smaller. So there are some regions in the X chromosome which are equivalent to the Y chromosome, and this is what we call as the pseudoautosomal region. There are, on the other hand, regions which are not common. So there would be a risk of having double amount of genes for those regions, and that's why they are inactivated. And this inactivation site is basically controlled by a small group of genes which are themselves there in the X chromosome, which are known as XIST, or the X inactivating site, which will basically destroy all or inactivate or imprint all the genes which are there in the X but not on the Y. What it basically means is that there will be some regions which are shared and common to these, which behave like a autosomal genes. So while we're talking about sex chromosomes, there are also the pseudo-autosomal region which behaves like the autosomal gene, and these genes are basically responsible for manifestation of Turner syndrome. So essentially what we're trying to say is that Turner syndrome represents the deficient action of the particular gene which is deleted, which is in the pseudo-autosomal region. Now, there is a pseudo-autosomal region, one which is very, very significant. It is on the end of the chromosomes, both X and Y. And this actually has got a number of important genes, the most important from the growth and the skeletal perspective is the SHOX gene. Now, this SHOX gene is responsible for growth, and in Turner syndrome, you will have only single expression of SHOX. And this is what causes growth failure. Now, what are the conditions in which you have got multiple SHOX expressions? Sign. So if you have Klinefelter, you will have 3, but again, you will have lionization. So it will not have that much. Other condition, Pratik? So if you have XYY, there is no lionization, you will have 3 SHOX. So they will be the tallest individuals there. So in a way, you can think of as a dose response. If you have got 2 SHOX, you've got an average height. If you've got 1 SHOX, which will go basically towards the possibility of a basically a Turner syndrome, the growth will be compromised, while if you have got multiple shocks, you will be taught. So this is like a dose response which is there, and shocks is not only responsible for growth, it is also responsible for other skeletal manifestations like brachymetacarpia, like the mad lung deformity, and it has now been shown that individuals who have got very quote unquote idiopathic short stature, a number of them may actually have a shock gene defect. And secondarily, you have a genetic syndrome which is known as the Léri-Weill chondrodysautosis, in which you basically will have a SHOX defect. So SHOX is an important gene because it's a contiguous gene deletion. The SHOX will be affected in Turner syndrome. The second, of course, in that regards is the BMP15, which plays a very important role. Of course, when we talked about the ovarian development, the bone morphogenic protein plays an important role in the ovarian development. We have got the TIMP region, which is important for cardiac development. So now you can really understand when we say syndrome, and all those findings were described of short stature, ovarian problem, cardiac problem, they were when the genetic diagnosis was not there. Now what you can understand that every Turner will not behave the same. Some may have the whole X chromosome which is gone. In some PAR1, some gene will go, in some multiple genes will go. So the manifestations therefore have to be heterogeneous depending upon how much the manifestations are. But if you talk about the classical presentation, it's basically this PAR1 which is responsible for this classical presentation. The second gene, which is the PAR2, it's actually on the Q arm. So this was in the short arm and this is in the long arm. And here you have got specific genes which are there. The most important is the fragile X-related mutation, and these are responsible basically for some of the ovarian functions. So if a girl has got a deletion in the PAR2 region, the major manifestation will basically be in the form of an ovarian problem. You may not have that SHOX defect, you may not have the cardiac defect, you may not have the other lymphedema and all those things happening. It's basically a problem which is happening at the level of the ovarian. So very distal defects in the XQ region are considered to be a premature ovarian failure rather than Turner syndrome. Because if you label somebody as Turner syndrome, it has implications in terms of monitoring, cardiac, all those issues come up in that regards. So depending upon which region is affected, the manifestations will present like that in that perspective. There's also a lymphedema region, which is not very clear, which basically causes the lymph development. And if you have that affected, there will be lymphedema, which will cause cardiac problems, which will cause renal problem, which will cause your webbing of neck, and all those problems will come up from that in that perspective. Now, in this situation, if we now look at essentially what's happening in Turner syndrome is that you've got one X chromosome which is intact, the other X chromosome either completely or partially is inactivated. The genes in that are not working in that situation. There could be a situation wherein the chromosome may be disrupted and then it will rejoin as a ring chromosome. So these are the all manifestations which we'll discuss subsequently, and that will determine the type of manifestations that are there in this situation. And if you have a ring chromosome, particularly affecting the XI-ST region, there will be issues of development, syndactyly, there will be much more syndromic effects which are there. So they are beyond Turner syndrome in that perspective. So we need to be aware about the genotype, phenotype association, and often when we read the karyotype report, we get confused. So we need to understand what exactly does this karyotype mean, because they will have significant implications in terms of diagnosis, assessment, and management in that regard. So therefore, different parts will have different regions. So just to explain that, we knew that SHOX gene is the major one which regulates growth. Abnormality in SHOX causes short stature and mad lung deformity. BMP15 is more like an ovarian gene. TIMP are basically for the cardiac development. FMR1 are more for ovarian. Again, deficiency there would call only ovarian failure with no other abnormality. And then we have got the lymphedema region. So these are more like a genetic defect. Now it becomes easier to understand rather than just saying that Turner will have so many manifestations from that perspective. And as I said, the XIST is the one which causes inactivation. So if you are not able to inactivate, you will have double dose of so many other sex chromosome genes. And there you will have mental developmental issues, syndactyly, and other abnormalities which will happen in that situation. So now the genetic spectrum of Turner syndrome is basically you have got an intact X chromosome and the other chromosome may be completely gone. This is what is known as the classical Turner syndrome, which will have the most severe manifestation. All these genes are gone. Second situation which will happen is that you basically have got duplication of the P arm. So you've got P and Q, your Q goes off and the P becomes double. So essentially you are losing that PAR1 region, which is the most important part. So this is known as a iso-XQ. This is a very, very common manifestation. The manifestation will be similar to a classical Turner because you will have cardiac, ovarian, and growth issue. But probably because the FMR1 region is there, your ovarian effects may not be that significant. They do have a propensity of an autoimmune thyroid disorder, which is more common in this setting in that regards. The other situation which may happen is that you may have just a distal deletion of P. Again, these two will behave like similar fashions. So this is a deletion of the P chromosome. You may have a distal deletion of the X chromosome, Q arm, which again will present more like a ovarian failure rather than more of a other classical Turners in that regard. You can have a ring in which the part of the P and Q are mixed up and you will have a problem. And if it is affecting the XIST region, as I said, you will have a lot of these mental retardation, brachydactyly, syndactyly, all these abnormalities can happen. And of course, there could be an issue in which you have got an additional Y line. And this is a big risk factor. If you have Turner syndrome with a Y cell line, there would be a significant risk of malignancy. So this should be considered if you have an obvious Y line, which is there on your chromosome, maybe around 7-8% may have that, or if you have a marker chromosome. So marker chromosome is a chromosome you don't know it's coming from X or Y, or if there is virilization which happens during puberty. So you don't need to do a Y line in everybody. It's not required, but it is required if you have a marker chromosome or if you have got this virilization which happens during puberty, which becomes significant from that perspective. So most common still is classical form. Many people debate that the classical form cannot survive. No other monosomy survives. So how they are surviving? Maybe there is some mosaicism in specific tissues. Maybe it's there that there are some cell lines which are still, which you are not detecting on your blood test, or that mosaicism is going off with age, and that's why you're missing out. So this is a debate. But if you talk about from clinical perspective, 45% of all your cases would actually be X0, and they will be the more classical. But you can have very mild manifestations with the other. So just to recapitulate, the classic form, your whole X chromosome is not there. The manifestations will have big in terms of classic presentation. Height will be like 20 centimeters below. They will be premature. There will not be any pubertal development at all. And growth failure and all the aspects will be there in this situation. The mosaicism is the other situation wherein you have a post-zygotic error. So some of them will have a complete classic X0, some will have X chromosome. So this, of course, is a dose effect. So the number and the distribution of the mosaicism will decide which way the girl will manifest. So classically, these mosaic forms will have a milder presentation than the classical form. So essentially what will happen here is that this post-zygotic defect and manifestations will cause more survival and higher growth as compared to the other individuals. So it's again because let's say you had got 1 shocks, normal has 2 shocks. If there is a 50% mosaicism, you've got 1.5 shocks. And that 1.5, it is more towards the growth plate. You may have complete shocks. So it depends upon when that mutation happens and which way they are expressed. So that's why the manifestations will be different. And often these are the girls who will present to you with spontaneous breast development, spontaneous menarche, and rarely they will have pregnancy as well. So it's not just the severity of the defect, it's also the extent, how many cells are affected will be important. So always look at the mosaicism part, which will give you the clue in that regards. Isochromosome Q is essentially a deletion of the P arm. So they will behave like a P deletion, in which in that perspective, as I discussed, So essentially what you are seeing is that these will present more like a classical form because P is the more important. So when we say typically diagnosis of Turner syndrome, usually a part of P becomes important. Otherwise, the manifestation may just be ovarian failure and you don't label them classically as a Turner syndrome. So they behave like classic form. Often there is mosaicism with X or XX, so the manifestation may be milder. They have a greater prevalence of a thyroid disorder, which is more common in this setting. Then XP deletion would basically be the part of the P chromosome may be deleted. And again, the manifestations would basically be depending upon how much it is deleted. So if you have a PAR effect, you will have short stature, you will have cardiac defect, you have effect on the ovarian functions as well. So effectively, it is more of the severe defects in that regard. Now, this is interesting. If you have an XQ deletion, you may actually escape most of the effects which are there in Turner syndrome. So these patients basically will have deletion of XQ and manifestations. Ovarian failure is more prominent because this is the fragile X premutation site. This will be, if it's distal to XQ24, you won't even label it as Turner syndrome. You will say it's more like a, this is what Naveen will talk about that, and we'll go from there. Now, very importantly, you need to identify the ring chromosome, where the abnormality is that the whole chromosome is basically cut and it forms a ring in that situation. And this presentation is very unusual because it will present basically more with features of mental retardation along with severity of skeletal dysplasia and growth failure. So again, this is distinct from the Turner syndrome if the XIST region is affected in that situation. Now, of course, Y cell line, which is an additional Y cell line, as I said, is present in around 10% cases in both covert and overt. All the guidelines for gonadectomy are based upon conventional karyotype. So you do not need to do an extensive search of the Y cell line because we don't know what happens if you do a routine detection, what that Y means. But if you find it on conventional karyotype, if there is a marker chromosome or if there is virilization, you have to really bother about that in terms of Turner syndrome. And manifestations basically is, of course, gonadoblastoma risk, which is an important factor. And if there is virilization, which means that there is a testicular tissue basically which is present there, and gonadectomy is required. So what really is a marker chromosome? Marker chromosome is basically a chromosome which you don't classify as X or Y. So this looks like a small patch of chromosome which is lying there. You don't know whether it's X or Y. This is a risk factor. If there is a marker chromosome, you have to consider a Y cell line / gonadectomy subsequently because this is a risk factor. You don't know whether it's X or Y in that situation. So essentially, you have to go by a Y material that becomes very, very important in a marker chromosome. And there is a gonadoblastoma risk which is there. So now if I just summarize these findings, the classical karyotype is 45% cases, most severe, and you have to really be concerned about that. If there is a mosaicism, the manifestation is same but milder. If it's mainly a triple X mosaicism, that will become even rarer. The manifestation will become milder. So you will have triple X will give you more shocks. So you will have more tall there, while the shocks efficiency here will compensate for the height. Then if you have isochromosome Q, it's like a XP deletion, more thyroiditis, which is there. If it's a ring chromosome, more of a mental abnormality, more of syndectomy or the manifestations, and Q deletion, more of a ovarian insufficiency as we discussed. And of course, marker chromosome risk of malignancy will be there. So now we've discussed about the various genes which are affected. We need to understand why all these manifestations happen. So there are three cardinal things you have to worry about Turner syndrome: growth, puberty, and cardiac development. So we'll talk about what's the basis of their problems. So growth is really affected in Turner syndrome, and a lot of it is because of shocks. On an average, if you lose a dose of shocks, how much height is decreased? Naveen.
So again, there will be around 20 centimeters.
Yeah. So 20 to 25 is the entire Turner height loss, but I would say if you say shocks, it's like 10 to 15. Because if you talk about Klinefelter, they are 10 to 15 more. Klinefelter is a complicated thing. If you go by XYY, that's definitely 15. So one shock probably means around 10 to 15 centimeter loss, which is there. Along with the shocks defect, there is a growth plate defect, which is intrinsic there. There is skeletal dysplasia, which may affect. There will be estrogen deficiency, which happens. And of course, the pubertal growth spurt is not there. So while the growth hormone levels are normal in Turner syndrome, you have got multiple other factors which are affected. But that does not mean that if you increase growth hormone levels beyond the physiological range, there will be no response. There will be response, but it will not be equivalent to a growth hormone deficiency response. And this is what I will be taking up later on. So growth is affected, but your GH-IGF-1 axis will be normal. So you don't need to really do a GH-IGF axis evaluation. If you have a short curve with Turner syndrome, you exclude celiac, you exclude thyroid, you exclude systemic illness, go for growth hormone therapy in that situation, which is important. What about bones? So bones are also affected, and there are multiple factors which affect the bone health. The most important, of course, is the estrogen deficiency. So if you have less estrogen, your rank ligand will be more, your osteoclast will start acting more, and therefore you will have a low bone mass, which happens in this situation. And that, of course, will have an impact on the other aspects as well. There is a direct skeletal effect. So overall, they will have a lower mass, but because the size is less, you will disproportionately overestimate the severity of bone abnormalities in the setting of Turner syndrome. So you have to be careful about that. And that's why we say do not do a DEXA routinely unless you have completed your estrogen replacement. Because if you're not completed your estrogen replacement, one, they have not reached the peak bone mass, which will cause a confusion. The bone size will be less, which will be a cause of confusion. But yes, BMD is decreased. But if you give proper growth hormone, if you give proper estrogen, you will have a normal sort of a bone density in that situation. The other thing, of course, is that vitamin D plays a role. There is a risk of increased fracture because they have more incoordination. Because Turner patients tend to fall more, they are a bit having difficulty in a visuospatial manner, so they tend to fall more. The cortical deficit is there, and the thickness of the bones are less. So the bones are not only light, they are less thick in the edges, so they're easier to break. So you have to be careful about that in that perspective. But the treatment is mainly estrogen. You don't start a bisphosphonate unless and until you have given enough estrogen, and despite that there is a fragility fracture. Because the problem is estrogen, problem is not of an increased resorption for any other thing. So estrogen is the best anti-resorptive agent you can think of in that situation. Ovaries, what do you think what happens to the ovaries? Is it an ovarian dysgenesis sign? Is Turner syndrome an ovarian dysgenesis?
Sir, the formation is okay,
Yes.
but it leads to early failure.
Yes, so a very, very important thing to remember is that people say that this is ovarian streak gonads, ovarian dysgenesis. No, the ovaries are perfectly normally formed. They behave like normal ovaries. But what is happening here is that they tend to have a earlier atresia, which happens attrition. So even in normal situation, girls will lose 90% of their ovarian follicles by the time they are born. Sort of millions of them, the numbers will be less. By the time they enter puberty, the numbers will be very, very high. So what happens in Turner is that the same thing is accelerated. So you'll have a rapid decline in terms of ovarian function, but it's not a dysgenesis in that situation. So what you see here is that lot of the girls will actually have lost their ovarian functions by the time the girl presents to you. In Turners, this is shifted to the left. So even at birth, the follicle numbers will be very less. Now, of course, the more the FRM you are expressing, the more BMP you are expressing, the ovaries may be preserved. If there is a mosaic form, it may be preserved. If it's affecting just one part of the X chromosome, it may be preserved. So, although classic Turner would rarely enter puberty, a reasonable number of girls with Turner syndrome who are non-classic mosaic will actually enter puberty, which you have to be wary about in that regards. And if there is a mosaic form, if the AMH level is detectable, if the FSH is not high, it is suggested that there is a chance of having a normal pubertal development which may happen in that situation. Last, very important, so we've talked about growth, we've talked about the pubertal aspect. The next very important is, of course, the risk of malignancy. So if there is a Y cell line, essentially what it is doing is that it is producing certain areas which are differentiating into testes. So maybe that particular gonad has got some testicular tissue. This is a very, very crude way of understanding, but this is what is happening essentially. And this will have a risk of developing malignancy subsequently. And this is something you have to be concerned about in that regard. So there is a risk of virilization which will happen. The gonad may get converted into gonadoblastoma, which is basically a benign condition. But this gonadoblastoma has a high risk of developing germinomas, which Pratik had talked a lot about the IDST talk when we discussed about that. So 10 to 30% risk of gonadoblastoma is there, and then you develop this germinoma. So this is something which you have to be careful about, and therefore prophylactic gonadectomy is recommended. So as we discussed, Turner syndrome affects the skeleton in everybody. All girls will be short. Ovaries in a good number of cases. Cardiac, again, very common. We'll talk about all these individual things later on. Renal abnormalities, again, because of edema. So whatever the fetal edema is there, the kidneys cannot come up. So if kidneys cannot come up, they have a horseshoe kidney. So all these are more of a mechanical problem which is there. Then hearing, because of the structure. So the way the ear tubes are made, they are more prone to infection, and then they develop sensory neural hearing loss later on. There could be a problem of the liver, and this may be the hepatic or even the intestinal function may be affected, 30 to 40%, and then eyes, ears, autoimmunity. We'll talk about all that which are affected in Turner syndrome. So now we've discussed a lot with regards to the basics of it. We'll go into the clinical part of pointers and criteria, and we will see if there are any questions. So you are all you can ask questions through the Q&A. So if there are any questions, we'll take it up from that perspective in that situation. So now Pratik, you can come up and you can carry forward.
Thank you very much, sir. So I will be discussing about the pointers and criteria via which we can help diagnose or at least see whether a girl fits into the pointers and criteria of Turner syndrome. So a girl with Turner syndrome, when she walks into her OPD, she might have few, she might have none, or she might have all the pointers of criteria which occur in Turner syndrome. And the most striking ones of all of them are the skeletal abnormalities. So the skeletal abnormalities are mostly because of the SHOX defect. The SHOX gene is expressed everywhere, from the face, from the facial muscles, to the trunk, to the arms and the limbs, and which ultimately results in the following criteria and the pointers. So as we know, there is a defective vertical growth with a relatively normal horizontal growth. So this gives rise to the classical stocky appearance which you see in these girls. There is also pectus excavatum which is associated. There are widely spaced nipples and basically a shield chest, shield-like appearance. The trunk is in the form of a trapezoid, meaning it is more of a broad shoulders and narrowing towards the pelvis. So as I said, stocky appearance, widely spaced nipples. An important aspect of the skeletal abnormalities lies in the carrying angle. So the carrying angle is what we call as the cubitus valgus, an increased carrying angle. This angle is mostly formed between the arm and the forearm, and it is measured usually by a goniometer. You cannot just measure it, but 6 to 12 degrees is normal, and more than 15 is considered high. And this is quite prominent in those who have Turner syndrome. Micrognathia, again, various facial features are there. So like they have the characteristic eye. Let's talk about the face. If we come to the face, the eyes, such as they have ptosis, they have strabismus, and this gives like the classical look where they're trying to look through those narrow palpebral fissures, and they have tilted chin forwards, and their head is tilted backwards. Coming to the ears, they have features such as large concha, they have posteriorly rotated ears, they may also have low set ears in that regards. Now coming to the upper limbs, in the upper limbs, let's begin with the forearm. In the forearm, we might have a Madelung deformity, where there is an ulnar subluxation. And one thing which is classically shown here is the brachymetacarpia, which is due to decreased growth of the fourth metacarpal, or brachymetatarsia, that is in the fourth metatarsal. Now, this is mostly found in wherever there's a Shock's defect. So, of course, Turner syndrome, Léri-Weill chondrodysautosis, and pseudohypoparathyroidism can also find these features. Apart from that, there might be various nail deformities. So we might have hyperconvex nails. We might have a single Parmack crease also might be present in these. And also these upturned nails, which are because of lymphedema. Kyphoscoliosis, coming to the spinal defects. So kyphoscoliosis is present in a majority, like 30% might have kyphosis and up to 50% might have scoliosis, which may be aggravated due to growth hormone therapy. Now, as I mentioned, the facies, they might have ptosis, the low set tears, which I've already explained. Now, this is very important, the webbing of neck and the low posterior hairline. So the low posterior hairline is caused because of the lymphedema. There is an initial lateral low hairline which swirls upwards as you go medially, which is same present on the other side as well. High arched palate, again because of lymphedema and developmental problems, it can cause difficulty in swallowing and phonation. An epicanthal fold. So this epicanthal fold per se does not cause any problem, but it's characteristic in about 30% of girls with Turner syndrome. It is a mild, small fold in the medial side of the eye. Now coming to the pubertal progression. Now we know any form of unexplained ovarian insufficiency, first thing, think of Turner's. But it's not always true that they may not have pubertal progression. In fact, 15 to 30% girls with Turner syndrome, they enter spontaneous puberty. 6% of girls might even have a spontaneous menarche, and less than 1% actually might have a successful pregnancy. But certain factors are there which help in assessing whether they will have a successful pubertal progression. These include a normal FSH, Mosaicism, more of Mosaicism, better the chance of pregnancy, pubertal progression, and AMH levels also help us decide whether they are going to progress in puberty or not. A very important fact is that the HPA axis is absolutely uninvolved in Turner syndrome. So they have a normal adrenarche, which is absolutely apart from the HPG axis defects. Now coming to a very important part, that is the cardiac malformations. Coming to the structural malformations, these are mostly congenital malformations, beginning with the coarctation of aorta, bicuspid aortic valve, pulmonary venous defect, and hypoplastic left heart, amongst many others such as transverse aortic arch, VSD, ASD, and other problems. From all of these, bicuspid aortic valve is by far the most common, occurring up to 1/3 of the girls. This per se does not cause any problem per se, but it is a big risk factor for the devastating complication of aortic dissection. Coarctation of aorta causes asymmetrical pulses, so it is absolutely important to measure all 4 limb pulses and also maybe do all 4 limb blood pressure. There might be hypertension also in these individuals. Pulmonary venous defect may present as pulmonary hypertension or exercise intolerance, and we all know that hypoplastic left heart may have devastating complications. All these risk factors give rise to a combined defect called as aortopathy, which means the decreased strength of the aortic wall, which may predispose towards aortic dissection. ECG changes include short PR interval, long QT interval, and right axis deviations. So drugs which increase QT intervals, such as verapamil and other drugs, voriconazole, etc., should not be given in these individuals. And if you have a QT interval more than 460 milliseconds, it is imperative we do a Holter monitoring to rule out any other abnormalities. Now, hypertension may be present in up to 1/3 and even up to 50% of individuals. It is important that we do a manual reading because digital reading might show false results. And of course, because of this autonomic dysfunction which is present in these individuals, we might have the loss of nocturnal dip which occurs in normal individuals. Hence, an ambulatory blood pressure monitoring might help us find that and help us towards guide us towards the diagnosis. Now, lymphedema is important. It is mostly a cosmetic problem. Basically, it is occurring due to the lymphatic obstruction which occurs in the neonatal period. Now, it may range from mild just obstruction, which may go up to cystic hygroma and very severely hydrops fetalis. But if all that is resolved, it leaves back some features such as this web neck. In infancy, there might be leg and hand swelling, nail abnormalities such as your hyperconvex nails, and the impact, as we said, webbing of neck and shield chest, and manifestation as posterior hairline and nail anomalies. Now, ophthalmic abnormalities, these are very important deterrents in the quality of life of these individuals. So beginning with the vision, myopia and hypermetropia may be present, and myopia much more commonly than hypermetropia. Red-green color blindness in 8% and amblyopia in 15% individuals may be present. Structural problems mostly because of the lymphedema causing squint, epicanthal fold, and ptosis, giving the characteristic Turner look. And the complications may include various glaucomas, cataracts, and retinal vascular defects such as retinal detachment. Now, cutaneous manifestations, as we know, their nevi is very common. So they have these nevis on the face, on the skin, and multiple are there. And these tend to increase with growth hormone therapy. Now, a very characteristic neoplasm of the hair follicles is the pilomatricoma, which may occur in up to 3% girls. They have melanoma risk, but it is slightly more than the normal population risk. And they have a high propensity of having keloid scars as well. So now coming to a very important point, pointers and criteria. So why are these important? Of course, we should not underdiagnose, we should not miss a child of Turner's, and we should not overdiagnose as well, not overdiagnose Turner syndrome. So any one of the major criteria or any two of the minor criteria should be involved before getting the evaluation. So beginning with any antenatal, so very high pretest probability things such as high cystic hygroma found in the ultrasonography, any of the cardiac defects, as I mentioned earlier, unexplained growth failure, unexplained ovarian failure, and one of the if facial features are present, any one of the major criteria is enough to go forward with the evaluation. Coming to the minor criteria, here two of them should be present. So renal abnormalities such as horseshoe kidney, duplication of kidney, or any unilateral agenesis, skeletal abnormalities such as your cubitus valgus, all other deformities, nail abnormalities such as hyperconvex nails, and any woman with hearing defect before 40 is an important pointer towards Turner syndrome. Now, antenatally, as we know, we may get a lot of women who are more than 35 years old, high risk of Turner. So we need to know what all criteria should be there antenatal to check these women. So the pointers towards antenatal diagnosis is an increased nuchal translucency, hydrops fetalis, cystic hygroma, renal anomaly, short femur, most of them caused due to lymphatic obstruction. Now the test done here, initially it is the chorionic villus sampling and later it is the amniocentesis. As believed earlier, the NIPT, the non-invasive prenatal testing which is done of a cell-free DNA of the maternal blood. It is now highly unreliable and should always be, if done, if positive, should be confirmed later with either CVS or amniocentesis. And pre-implantation techniques for artificial reproductive techniques should be done by next generation sequencing. As I mentioned, the pretest probability highly increases if the pointers are present. So if you have an ultrasound which is showing cystic hygroma or any of these, it is highly possible that the karyotype will show a positive XY Turner syndrome. And if you have just a karyotype which is just showing XO, just with no other signs such as these increased nuchal translucency, etc., it is highly unlikely that this individual will be Turner syndrome later on. So now coming on to a very important aspect, who should we label as a Turner syndrome? Not every girl who has short stature, etc., who you think is Turner syndrome might be Turner syndrome. So the first important criteria includes it has to be a phenotypic female. So male gender, not Turner syndrome. Any DSD, not Turner syndrome. Any of the clinical manifestations, as I had mentioned earlier, think of Turner syndrome. So if any woman comes with a clinical manifestation, next step is to do a karyotype. Now, certain things we need to consider in the karyotype. First of all, according to the AMCG, the American College of Medical Genetics and Genomics, we should do a minimum of 30 metaphases to look for the defects. And if we don't find in them, you can do even more, up to 50. Now, as we know, with increasing age, the bone marrow starts producing lesser and lesser of these abnormal cells. So they might not be present in the peripheral circulation. So if you have a high suspicion of index of suspicion, you might as well take a sample of fibroblasts, urine, and buccal mucosa if your peripheral circulation testing comes normal. So if your karyotype is done, the next step is to see you must have an intact X chromosome. The other might be deleted entirely or a part of it might be deleted. So as I had mentioned, male gender, atypical genitalia is ruled out. Now important, as Sir had also mentioned, a deletion distal to Q24 is primarily only involving the ovarian problems. So these are not termed as Turner syndrome and as termed only as ovarian insufficiency. And as we know, mosaicism slightly increases as increasing age. So below 5% mosaicism after 50% is not considered Turner syndrome. Now there is a high malignancy risk in Turner syndrome of gonadoblastoma, normally in 7 to 8%. But as we mentioned earlier, any Y line which is detected by conventional karyotype, there is a 10 to 30% increase in these malignancies. Other malignancies, there's a slightly higher risk of meningioma and colonic cancers. And in breast cancer also, there's a slightly risk. Okay. Sorry. Now comes to the important part of screening for Y material. Now, why must we do this? Because of the risk of gonadoblastoma, which might progress to a dysgerminoma. So the indication, not all Turner syndrome need to undergo a screening for Y material. So only if you have found a marker chromosome, that means we do not know what that chromosome is. It may be X, it may be Y, it may be anything else. Or you have features of virilization, means there's a Y cell material is active in the sense of virilization, hirsutism, musculature, clitoromegaly. We should look for a Y cell line. Now the test is characteristically FISH. Now again to the AMCG guidelines, you need to do a minimum of 200 interfaces with X and Y centromere probes. And the role of this is again to prevent gonadoblastoma by doing an early prophylactic gonadectomy. Thank you.
Thanks a lot, Dr. Pratik, for this discussion, and it became very easy in terms of the further assessment. So we now know what are the basic pointers and what are the various criteria which are there with regards to Turner syndrome. We'll now move forward towards assessment, and we know that different parts of the body may be affected by Turner syndrome, including growth, puberty, heart, in terms of kidneys, hearing, and all the other issues. So we'll now invite Dr. Naveen, who is a fellow in Center of Diabetes Endocrinology and Research, to come up and talk about the evaluation from there.
As Dr. Pratik has mentioned in detail regarding the various manifestations of our children with Turner syndrome, now the next step is regarding the assessment. A good assessment of a child with a Turner syndrome include careful and complete evaluation for the presence of other comorbidities and its complication. The complete evaluation of a child with Turner syndrome includes clinical, laboratory, and thorough cardiovascular evaluation. First, clinical evaluation. With respect to clinical evaluation, we need to do it during every clinical visit and as soon as the diagnosis of a Turner syndrome is being made. First and most important is the growth, which is being affected universally in all patients of Turner syndrome. We need to have a complete assessment of the various growth parameters, and we need to plot the growth with respect to both the IAP and WHO and also with respect to Turner's chart. The most important aspect is that whenever we file a child who is growing less with respect to that of a Turner chart, we need to think of other comorbid conditions such as celiac disease and hypothyroidism. And whenever if a child is growing less than 5 percentile on an IAP on standard growth chart, we need to think for a possibility of giving growth hormone therapy. And it has to be started as soon as the diagnosis is made, and it has to be done during every clinical visit on also at least in a minimum period of every 6 months. Next important assessment in case of a child with Turner syndrome includes assessment of the pubertal status. We need to start as soon as after child has attained around 10 years of age, and we need to look for any discrepancy between the adrenal and the hypothalamo-pituitary gonadal axis, or the discrepancy between the pubic hair development, and also the breast development. And third, hearing. Hearing, we need to have a clinical examination regarding is there any association with infection in the form of any ear discharge, or you need to look for the presence of any throat infection, because ear infections or middle ear infection is considered to be more common in a child with Turner syndrome, and good assessment and thorough and aggressive management of these infection can prevent the development of conductive hearing loss. And hearing assessment, which includes the evaluation for sensorineural hearing defects, should be done every 3 yearly. And the most important part of assessment, as soon as the diagnosis of Turner syndrome is made, is the monitoring of peripheral pulses and blood pressure. We need to look for all the peripheral pulses, whether they are palpable, so as not to miss coarctation of aorta. And the most important and the mandatory thing is to recording of blood pressure. It has to be done and via the manual sphygmomanometer rather than using a electronic, because there is increased chance of development of error with respect to electronic sphygmomanometer. And most important, at least during once or in the beginning of diagnosis, we need to monitor all the 4 limbs to look for the presence of asymmetric blood pressure or hypertension, as asymmetric blood pressure could occur in coarctation of aorta, so it should not be missed out during a routine clinical examination. And hypertension is also considered to be more common with children of Turner syndrome, and it is one of the important risk factors for the development of aortic dissection. We should not miss monitoring of blood pressure during every clinical visit. And next requires the eye examination. It has to be started after 1 year and has to be done every 3 years. And already mentioned by Pratik, we need to look for the presence of refractive errors, which is in the form of myopia, hypermetropia, amblyopia, and look for other structural defects such as ptosis. And also you need to look for various complications such as glaucoma, cataract, and retinal detachment. And kyphoscoliosis examination usually starts only after 5 years of age, and it is more when the patient is on growth hormone therapy. Next comes the laboratory investigation. Here we need to look for 3 important profiles with respect to laboratory, which is the autoimmune, metabolic, and imaging. This will be explained in the following slides. And as Saura has already mentioned, DEXA scan, which is usually done only after the child has attained the adult height and estrogen treatment for the fusion of the bone has completed. Because if we actually do it before 18 years of age, we will overestimate low bone mass. And it has to be done every 5 years after the child has attained the adult height and the estrogen treatment for bone fusion has been complete. Next, it is very important that we need to supplement vitamin D on a regular basis, and assessment can be done every 2 to 3 yearly. And dental examination should start after around 7 years of age, and we need to look for malocclusion, micrognathia, as they are more prone for many dental abnormalities. The most important aspect in a child with Turner syndrome is the cardiac workup. The cardiac workup is more important because the most common cause of morbidity and mortality in a child with Turner syndrome is the cardiovascular complications, which is the aortic dissection, which is the most common, which is about 100 times more common in a child with Turner syndrome with respect to that of the general population. So whenever a child is being diagnosed with a Turner syndrome, first and foremost, which I already mentioned, is to monitor the 4-limb blood pressure to rule out coarctation of aorta and also hypertension. Then we need to do an ECG, as Pratik sir has already mentioned, various ECG abnormalities with respect to conduction abnormality in the form of short PR interval, right axis deviation. If a child who is having right axis deviation, then we should probably think of doing a cardiac MRI to rule out pulmonary venous defect or any partial anomalous pulmonary venous communication. And ECG usually done at the baseline, and in case of is there any abnormality, then we need to do it on a routine basis, or else a baseline ECG is important. And another abnormality with respect to ECG is prolonged QT interval, and azithromycin being commonly prescribed in the COVID era, it is one of the important drugs which can cause prolonged QT interval. So it is always mandated to have a ECG checkup at the time of diagnosis in children with Turner syndrome. Next important thing is Imaging, we need to do two types of imaging, which is more important. First is the 2D echo. 2D echo, which basically is usually done in younger children and also in infancy. And other important thing is the MRI, which is to be done after 12 years of age to rule out aortic dilatation. And this MRI has to be repeated based on the risk for development of aortic dissection. 2D echo is basically done to rule out various cardiovascular abnormality, which Pratik sir has mentioned in detail. They have bicuspid aortic wall, coarctation of aorta, and other abnormalities. But MRA is considered to be more specific for identification of aortopathy rather than 2D echo. That's why we usually prefer doing an MRA after 12 years of age. And the follow-up depends on the aortic size and also depends on the various risk factors. And the follow-up has to be done either 5 years or 1 year or every 6 monthly. It is based on the risk factors. And whenever if you are planning pregnancy or during pregnancy, a complete cardiovascular workup has to be done, because the risk of development of life-threatening complication during pregnancy is very high. Approach to cardiac management. As already mentioned, we need to do the basic workup, which includes the ECG, 2D echo, MRI, and BP. And on the basis of the above results from ECG, echo, MRI, and BP, the important risk factors for the development of aortic dissection include the coarctation of aorta, bicuspid aortic wall, and hypertension. Apart from this risk factor, the most important determining factor for the development of aortic dissection is the aortic size. So based on these two factors, we usually delineate the patients with mild, moderate, and severe risk, and we generally follow up the patient on the basis of severity. In a patient with no risk factors and aortic size which is less than 3 standard deviation, then he has a very small risk of developing aortic dissection, and we need to do a MRI every 5 yearly or an echo every 5 yearly. If a patient has no risk factors but aortic size is more than 3 standard deviation, then he has a moderate risk of developing aortic dissection, and we need to monitor, do a cardiac MRI every yearly. And the patient is having a aortic size of less than 3 standard deviation, but with the presence of risk factors, then also we need to monitor every 1 yearly. In the patient with both the presence of risk factors and aortic size more than 3 standard deviation, then he has a very high risk of developing aortic dissection, and he has to be done followed up every 6 monthly with 2D echo and cardiac MRI. And the other conditions which are basically associated with Turner syndrome includes the renal manifestation, which, as Anurag sir has already mentioned, because of the presence of lymphedema, there is a difficulty in the ascent of kidney during embryological development. So as a result of which, there are various anomalies which include the horseshoe kidney, duplication of the renal calyces, renal pelvis defect, and unilateral renal agenesis. Whenever when we do a USG and whenever we find a defect, we need to follow up them on a regular basis in the form of doing a yearly renal function test and yearly USG to look for any obstruction and presence of pyelonephritis and scarring of kidneys. And ENT issues. ENT issues, as Sarah has already mentioned, due to the abnormality of the skull bone development, and also there is an abnormality in the eustachian tube and the middle layer. There's an increased risk of developing recurrent middle ear infections, which will land up into development of perforation and finally end up in cholesteatoma, which cause profound conductive hearing loss. As because of the congenital anomaly in the cochlear development, these patients already have an increased risk of developing sensorineural hearing loss. When this is being compounded by the conductive hearing loss, the hearing loss becomes too severe, and they usually require the use of cochlear implant when they are becoming adults. So to prevent these the development of sensorineural hearing loss, we can monitor the patient on a clinical basis and do routine evaluation of the ears so as to prevent the middle ear perforation and cholesteatoma. And the sensorineural hearing loss, which usually occurs in the adult age group, is usually in the frequency of between 1000 to 2000 hertz. As already mentioned, the cause of conducting hair, which usually occurs during childhood, is the recurrent infection and palatal abnormality, and the cochlear defect, which is responsible for the sensorineural hearing loss. And this auto ENT issues are more common with children with classic classic picture of Turner syndrome and also with ISOQ karyotyping. And complication requires surgery and cholesteatoma. Gastrointestinal. This is a very rare complication with respect to gastrointestinal. There is an increased risk of development of hemangioma and telangiectasia, which can cause profound GI bleeding, which sometimes requires surgery where we need to do intestinal resection. And as already mentioned, there are various autoimmune diseases which are associated with Turner syndrome, and one of the most common, which we need to suspect when a child is growing below the level of Turner's chart, then celiac disease has to be suspected. And in IBD also has to be suspected in a adolescent child who is presenting with a classic feature of delayed puberty and failure to thrive apart from various gastrointestinal manifestation. And the risk of developing celiac disease is around 2.5% in a children with Turner syndrome, and IBD is around 3%. Liver, there's mild transaminitis, which is causing a mild elevation in SGOT and SGPT levels. But as such, in contrary, replacement with estrogen generally causes decline in these levels. And autoimmunity, one of the most important autoimmune conditions is the autoimmune thyroid disease, which is generally seen around 15% of children with Turner syndrome. So we need to start monitoring as early as possible. And this monitoring of thyroid function has to be done annually and has to be done throughout life and has to be include the thyroid function test. And as Sarah was already mentioned, it is more common with ISOQ. And gastrointestinal, and as is already mentioned in the previous slide, and rheumatology, it's variable and the exact association is not known. And metabolic issues, there's an increased chance of developing diabetes mellitus, but it is both type 1 and type 2, which are both common, but the exact cause is multifactorial. If the X deletion is being maternally inherited, then there's increased chance of developing adiposity, which could lead to insulin resistance. So one of the other factors also includes the various growth hormone, estrogen replacement therapy, which also cause an abnormality in carbohydrate metabolism, which could land up in type 1 and type 2 diabetes mellitus. And this in turn increases risk for coronary artery disease and development of stroke in the children.
Thanks a lot, for really focusing on this very important aspect. So this sounds a very extensive part in terms of what needs to be done, but it's really a challenge because these individuals have got a big part of a whole chromosome is gone. So if you see any other chromosome, if it goes, the patient cannot survive. So this child has got a lot of burden, and that's why we have to monitor for all those things. But if you understand the physiology well, if you understand the genetic evaluation well, and you really go deep in terms of the karyotype results, you will know which disorders are more likely in that regards. You have mentioned very importantly the effect of genomic imprinting, which is there. So where you get that X chromosome, which is intact from the father or the mother, may also influence the manifestation. So it's a very disease which requires a multi-speciality input, and you need a careful protocol. So there are guidelines which are there. So this is from the Cincinnati guidelines, which really wonderfully focuses on when to do the evaluation, how to follow up. So we have got specific proformas. So all of you can have those proformas and put up in that so that you follow them up meticulously. The key aspects to look, of course, is of growth, blood pressure. And blood pressure, I would say, is very important because coarctation of aorta, dissection of aorta, they are all related to blood pressure. So blood pressure becomes very, very important. Thyroid profile and TTG, don't miss it. Often people consider starting growth hormone and they haven't done that. So that is not something which is acceptable because that is, of course, very easily to treat. Look at metabolic complications around the 10-year mark, which is basically the puberty age group normally, which happens that way. Hearing, very important. If you have a girl with Turner syndrome who is deteriorating, who is not improving in terms of school performance, think of thyroid, think of hearing abnormalities in that perspective. Now, a lot of people think about the learning aspect as to what is affected and what is not affected in Turner syndrome. The intelligence is normal, but the performance may vary. They may be very good at language, but they may have some issues in terms of mathematical skills. They may have problems in communication. So they become more reliant, more dependent sort of a people. But overall, their intelligence is absolutely normal in that perspective. There can be some visuospatial issues. So they may find it difficult in terms of driving and those things, but otherwise learning is absolutely normal. I don't miss it. Cardiac, the most important, and we have done very well in terms of baseline. You have to do echocardiography, and after 12 years of age, MRI is very, very important to look at. And when you write a prescription, ask for what is the aortic size index, and less than 16 years of age, what is the SDS, because all your algorithm was based upon that. So you have to be wary about these parameters. Importantly, renal ultrasound, of course, at the baseline. Hip examination, that's more like a congenital problem, so you should pick it up early. That is like a CDH issues. Spine X-ray, if you're on growth hormone, you have to look for all these abnormalities and problems which happen in that regards. And bone density, don't rush. Do it only after you have achieved the sexual maturity, typically beyond 18-20 years of age, or if you have a fragility fracture in that regards. So now we've discussed a lot about the pathophysiology, the diagnostic criteria, which Pratik really mentioned very nicely, that you have to have a phenotypic female who has got a deletion of a part or entire X chromosome with no atypical genitalia. We've discussed a lot about evaluation. Now we'll talk about management. And there are three major parts of management. Essentially, we're talking about growth. We are talking about puberty. We're talking about heart. There are also issues about fertility, about support, and bone health. So there are multiple issues, but three things which we'll mainly focus on would be growth, cardiac, and pubertal reproductive issues in that regards. Now, growth, as we discussed, and if you can see, this is a classic publication which came in many years ago, which shows that these girls are normal probably at birth. So at birth, they are not really short, and they tend to be normal in the normal range, at least till around 4 to 5 years of age. But the growth faltering is starting a bit early. So if you want to intervene, some people thought you can intervene right at the toddler age to prevent this growth faltering from happening. They found good initial result with growth hormone, which of course will happen. But when you talk about the final height data, it did not give us a positive outcome. So we don't need to be over aggressive in terms of treatment. Probably 4 to 5 years of age is the right time when the girl will go off the chart. This is typically what happens in Turner syndrome. It is 100% thing. So short stature is universal in Turner syndrome. This is the most common manifestation of Turner syndrome. So they're slightly short at birth, low growth velocity, reduced pubertal spurt, of course, and you will have a compromised height by around 20 to 25 centimeters. If you talk about in Indian perspective, we're talking about 130 to 125. So basically by MPH, you subtract 20, 25 centimeters. This is what you're talking about. So growth is a big issue in terms of Turner syndrome, which has to be looked at. Key parameters, plot on a Turner's chart, because a Turner girl may have hypothyroidism. So she was growing fine on Turner's and then going off. It means this could be hypothyroidism. So you have to be wary about. But when you decide about treatment, you're talking about a normal girl's growth chart in that perspective. So if we focus mainly on the Cincinnati guideline, what it clearly says is that if the growth velocity is reduced, you can start thinking of a possibility of treatment. And if the height goes below the 5th percentile, you have to definitely consider treatment in that perspective. Now, very importantly, if the mid-parental height is low, you tend to be more aggressive in terms of treatment. So treatment depends upon a lot of factors. This is not the issue with the patients who come to us. They are really, really short, most of them. This is more like when they're coming to you at 3 years, 2 years, 4 years, when you are in doubt, you want to treat now or wait. Usually if they come to you by 10 years, or if they come to you by 12 years, which is a very common, or even after puberty, they are very short. So then the debate doesn't come up. This is more for the younger girls who present at that point of time. Most importantly, the dose is double. You cannot use the replacement dose because you have to give a pharmacological dose. So we're talking about 45 to 50. Some people have used up to 70, but that's like a too huge dose in that perspective. It may be appropriate to use a body surface area-based dose, milligram per meter square dose, especially for obese girl, because obesity tends to be high in the setting of Turner syndrome. So you have to be cautious in that regards. Do not go beyond 70. That's the upper limit, but that itself, the cost will become very significant at that point of time. Now, of course, how long to treat? People have definitely thought of that typically you should give at least 4 years of growth hormone before inducing puberty. But that often is not possible because girls are presenting even in US at the average age of 8 to 9 years. In India, maybe the number is 12 to 13. So you have to do a compromise. You delay pubertal induction. Maybe that will be one option. Or you give a high dose GH, or you add oxandrolone, which I'm going to talk a bit later in that regards. Of course, you don't need to do a GH IGF-1 testing because this is more like a pharmacological indication, not a physiological indication. Now, be realistic in terms of what the growth would be. There are not many meta-analyses which are there, only 2 studies are there. And what we see, if you treat for 6 to 7 years, you're gaining around 7 to 9 centimeters additional from the height. So if somebody was around 132, 134, you're reaching 141, 142 if you're treating for 6 to 7 years. So on an average, you gain 1 centimeter per year of treatment, which I would say is substantially lower than GHD and significantly lower than SGA. So Turner's is not a very, very remarkable growth. You have to explain this to the family before you start, but this is a very good option in terms of achieving. So if somebody was landing 130, you're taking 140, it may be reasonable. If you treat appropriately, many of these mosaic girls may go beyond 150 also, which is possible. Now, what you expect is that you have to monitor IGF-1 because this is a pharmacological therapy. You tolerate IGF-1 till 3 standard deviation score. In GHD, we say not more than +2 STS, but here you are actually giving high dose to ensure that your levels are high, but they should not go beyond 3 STS in that situation. Duration basically should ideally be till the bones are fused, so bones are 14 years and the growth velocity is not there. You need to be aware that since this is a pharmacological therapy, all the risk factors will be more likely. So they will develop more fluid retention, they will develop more benign intracranial hypertension, they will develop more hypothyroidism as compared to somebody who has a simple GHD in which you are giving half the dose. Very importantly, if any girl with Turner syndrome comes back after GH with complaints of headache, visual complaints, get a fundus because BIH is common. We have seen that. The other thing is that the slip capital femoral epiphysis is also much more common. It's just the rate of growth. So if the rate is growing fast, your epiphysis may just slip, which may happen in that situation. Glucose intolerance transient may happen. Frank type 2 diabetes is extremely unlikely in that setting. So don't worry about much. But one thing you have to remember is that because you're giving too much growth hormone, you may have increase in scoliosis. You may have increase in all the facial lesions which are there. Sometimes if hemangioma is there, it may grow up. If there are moles, they may grow up as well. There may be a disproportionate increase in the leg and hand because it's more like an acromegaly dose that you're giving. So these things you have to be cautious about and understand in that situation. So as I said, nevi may increase, the hand size may increase. There is a theoretical risk of pancreatitis, not very significant. Of course, you will have better lean mass with that. There will be benefits. And most importantly, it does not affect the heart. So there's no increased risk of coarctation, no increased risk of dissection and hypertension in this with regards to the use of growth hormone in Turner syndrome. Now, if you treat for a longer duration, if you give the higher dose, and if the parents are tall, of course, you will have a better response. So there are prediction models which are available. Pfizer has come up with the KIGS model, which provides you the information as to how much the growth potential you expect to grow in that perspective. So this is something you have to look into. And if you start early, you will have a better response in that regards. Now, till what age can you consider treatment? Because often these girls are coming to us at 13, 14 years of age. What do you do? If the bone age is like 12, 12 and a half, I would still give it a try because you intend to have a reasonable response in that setting which is there. Now, one issue which I said is that if the diagnosis is really late and the height is compromised, what should you do? One option is to use oxandrolone, which is basically a non-aromatizable androgen. So this is something which you can use. The problem here is that there is a risk of hirsutism or clitoromegaly, particularly if you're using a higher dose. So use a lower dose. Second is you start low dose estradiol, which is basically again not recommended because people initially thought that if you give low dose estradiol, growth may happen. This is even before puberty. This is around 6, 7, 8 years. But now one NIH study was there, no further study, and it's not been proven. So don't use a low dose estrogen. You may delay pubertal induction. And if you delay pubertal induction by 2 years, the benefits are as much as you get from oxandrolone. So if somebody is presented late, you've got two options, oxandrolone and start timely pubertal induction. If it's not available, costly, think of delaying pubertal induction. But how long will you delay is a question. Somebody comes to you at 14, do you want to delay to 16 or 18? That's nobody knows the answer. That's because of a resource issue that we are facing that problem. Very importantly, and Naveen had very clearly said that cardiovascular management is the key. So if there is a coarctation, you have to do the repair. If there is a vascular disease, valvular disease, you have to repair. But routinely, the risk of IE, infective endocarditis, is very less. So you don't need to give a routine prophylaxis for common procedures like dental procedures in that situation. You have to monitor blood pressure, and treatment-wise, ACE inhibitors and beta blockers are more effective in terms of outcome. If there is an increase with regards to the aortic size, you have to start, like there is guidelines for Marfan syndrome about aortopathy. Similar guidelines have been developed for Turner syndrome, that you consider starting beta blockers particularly. But if the size is significantly larger, early surgery is better, because dissection is the most common cause of death which will happen in the situation. As I said, avoid the QT prolonging drugs and monitor blood pressure, manage with beta blockers and ACE inhibitors, because hypertension, coarctation, they're all risk factors for dissection which are there. Now, aortic dissection, you have to worry, especially during pregnancy. So no girl, no lady with Turner syndrome should be allowed to become pregnant without a proper cardiac evaluation. That will be very, very important, because the risk is very high in pregnancy and it could be fatal. So if you have hypertension, bicuspid aortic valve, coarctation, even if it is repaired, the risk is very, very high in that situation. The predictors are the ASI, and you have to monitor the ASI as we've discussed. So you can use SDS below 16 years. Beyond that, use the actual size. So this is the size of the aorta at the largest point. So it's like diameter. If it's more than 2 centimeter per meter square, you have to worry. If it's more than 2.5, it's severe. Management, again, blood pressure control and appropriate timing surgery would be there. Very importantly, if you have a girl with Turner syndrome who comes to you with sudden onset shock and abdominal pain, always think of dissection as a possibility. That's a dire emergency. The patient will die if not taken up immediately in that situation. As Naveen said, there's 100 times risk of dissection. Usually happens much earlier than a normal woman will have 60 years. This will happen in 35 years of age. So very common, and the main cause of mortality which is there. Now, based upon your ASI, which we were discussing about, if it is between 2.5 to 3, intense activity should be reduced. If it's above 3 SDS, think of beta blocker and ACE inhibitors. Above 4, surgery. So this is most important when you send your patient for echo or MRI. Ask for this parameter. What is the ASI? What is the SDS? And this will give you the real picture in terms of that. So this is what has already been discussed as to how do you do the monitoring. Once you monitor, so basically you start monitoring with the cardiac and the transthoracic echo. If there is an increase in the aortic size index by more than 1 standard deviation score in 1 year, you have to refer the patient for surgery. This is something which you need to really understand. So the overall cardiac risk depends upon how much are the baseline comorbidities, coarctation, bicuspid aortic valve, and hypertension, plus what is the ASI. These are the only 2 things you need to remember, and then this algorithm will help you out in terms of evaluation. So a close link with a cardiologist is essential in that situation. So I think we've discussed about cardiac and growth management. Now I invite Dr. Sayan to discuss about the pubertal management here. Dr. Sayan.
As already mentioned by Anurag sir, in the setting of the Indian context, children with Turner syndrome are diagnosed late, mainly around 12 to 13 years. So as doctors, we are faced with pubertal issues at the onset itself. Now, as far as pubertal issues in Turner syndrome are concerned, what is the plan? we generally have to watch for signs of spontaneous puberty. And as you have already known from the previous speakers, that around 1/3 of patients will develop spontaneous thelarchy, while around only 6% patients will have spontaneous menarche. So if there are spontaneous signs of puberty, there is no need to induce it. So if there aren't spontaneous signs of puberty, what do we have to do? Generally, it has been seen that in Turner syndrome, 11 years is the kind of age when they develop signs of puberty. So if at 11 years of age, a child with Turner syndrome doesn't have any spontaneous signs of puberty, we go in to check the biochemical parameters mainly of the gonadotropins and also AMH and inhibin B. Amongst these three, inhibin B has the lowest specificity. So we mainly monitor for FSH and AMH. With a child who has normal gonadotropins and AMH, we can at the most wait up till 14 years of age if puberty is delayed. So what is the protocol we apply here? We start at around 10% of the dose and increase it to adult range over the next 2 to 2.5 years. The route is generally oral or transdermal, and I'll discuss the issue related to routes in the next slide. And we have to monitor for breast and uterine development, as I already mentioned, over a period of 2 to 2.5 years. And progesterone has to be added only after 2 years or a bleed has developed, because progesterone is the main issue which leads to restricted breast and uterine growth. So now coming to the estrogen route, when estrogen is given orally, there is generally a very high concentration of estrogen that is delivered to the liver, which leads to various complications. And it also leads to various effects on the blood vessels. So estrogen, when given via the systemic route, has been shown to decrease IGF levels. With effects on protein C, it has been shown to increase incidence of thrombosis. With effects on lipase, it has been shown to increase incidence of dyslipidemia, and on ANT2, leading to increased evidence of hypertension. So what is the next route via which we can deliver estrogen? The most commonly available and recommended route nowadays is transdermal estrogen. Transdermal estrogen is generally available in two forms, that is the matrix form and the reservoir form. So for pubertal induction in children, we require a very low dose, which is generally, according to the Scandinavian experience, can be given via matrix form. Now, matrix forms are generally available for the adult people, and the minimum and the most commonly available form has 25 micrograms. But we require 1/4 of that dose for pubertal induction in Turner syndrome. So in a matrix form, we can cut it and put the transdermal estrogen according to the dose we require. So the transdermal route has a normal IGF response. The hypertension risk is not increased. The chances of thrombosis are less, and there are no effects on binding globulin. While in the cases of estrogen, the adult dose is generally 2 milligrams per day, has an effect on IGF-1 axis, increased risk of hypertension, more chances of thrombosis, and the binding globulin effect is present. So the estrogen preparations generally available at this point of time are ethinyl estradiol, which is started at a dose of 2 micrograms, going up to 10 micrograms per day, but it is generally avoided due to its highly potent action and rapid development of features. The most commonly used oral preparation nowadays is estradiol valerate, which has an initial dose of 0.25 milligrams, going up to 2 milligrams, and this is more physiological. The conjugated estrogen is started at 1.5 milligrams, going up to 0.625 to 1.25 milligrams. And the recommended route is the transdermal estrogen, which is started at the initial dose of 3 to 7 micrograms per day, going up to 25 to 100 micrograms per day, which doesn't have any effect on the IGF-1 axis. So as I already mentioned, the transdermal route is preferred. So I can't see what is it.
So gradual progression.
Achha, yes, sir. Gradual progression over 2 to 2.5 years, and progesterone has to be added only after 2 years or a spontaneous vaginal bleed. The progesterone preparations which are generally available now is medroxyprogesterone, which is started at a dose of 10 milligram, applied for a duration of 10 days, or a micronized progesterone at a dose of 200 micrograms for a duration of 12 days. Medroxyprogesterone generally has more progesteronic effect as seen by increased evidence of breast tenderness. It also has bone effects and also androgen effects. So micronized progesterone is generally preferred nowadays. And as I already mentioned, it has to be added only after breast development has been completed, after vaginal bleeding has taken place, or when endometrial thickness is seen to be more than 5 millimeters. Coming to the maintenance therapy of the secondary sexual characteristics, we have two options. One is the estrogen progesterone pill, and the other is the Valerate, followed by the progesterone pills. As we already mentioned, as there is a risk of hypertension, we monitor for blood pressure in these cases. And we have two options related to the therapy. One can be monthly, and in those not wanting regular periods, it can be 3 monthly. There are definitely benefits with respect to bone density, as already has been discussed. There are various neuropsychiatric beneficial effects which are also seen, like increased motor speed, verbal and non-verbal communication betterness, and increased self-confidence. Now, in cases of Turner syndrome with estrogen deficiency, there is increased incidence of hepatocellular lipid deposition, which leads to liver dysfunction. All of this can be attenuated by adding estrogen at the right time. There is also benefit with respect to adiposity, growth, and decreased aortic stiffness with therapy. Now coming to the fertility options, we have the option of oocyte preservation, which can only be undertaken after 12 years of age and in those with normal AMH and FSH. The oocyte preservation, the retrieval process of oocytes can only be done after 12 years. Cryopreservation has also been tried before ovarian failure, but various studies have shown that it has a very limited role. Oocyte donation can also be tried in those having a normal uterine growth, but there are chances of various risks of complication, as already has been discussed, mainly with respect to the cardiovascular complications. So the fertility options mainly depend on the age. In those with less than 12 years of age and having AMH normal more than 2 nanograms per ml, we go in for a follow-up. In those less than 12 years with AMH less than 2 nanograms, we can try ovarian freezing. In those greater than 12 years of age, which AMH more than 2 nanograms per ml, as already has been discussed in the last slide, we can try for oocyte freezing. But those with AMH levels below 2 nanograms per ml, we will have to go in for oocyte donation. Now coming to the artificial reproductive techniques, the various contraindications to these procedures are aortic dissection, an aortic size index of more than 2.5 centimeter per meter square, previous conditions with respect to coarctation, bicuspid aortic valve, hypertension. Now the workup in such cases will need an echo or a cardiac MRI and has to be done within 2 years of the artificial reproductive technique. The procedures hereafter can be a surrogacy. Now coming to issues of pregnancy, pregnancy has to be avoided in cases of aortic dilatation, bicuspid aortic valve, aortic dissection, and elongation of the transverse aorta. The monitoring in such cases, as already has been mentioned, as hypertension is a risk factor for aortic dissection, the BP has to be maintained below 135 by 85 milligrams per Hg. Echocardiography has to be done in 20 weeks. 4 to 6 weekly echocardiography is recommended if the aortic size index is more than 2 centimeter per meter square, and this has to be followed up 6 monthly due to the increased chances of aortic dissection post 6 months, postpartum 6 months. Now the delivery mode is according to the aortic size index. If the aortic size index is less than 2, we can go in for a vaginal delivery. If the aortic size index is around 2 to 2.5 centimeter per meter square, we can go in for a vaginal delivery with epidural anesthesia. But if the ASI is more than 2.5, we definitely have to go in for a cesarean section. Thank you.
Thanks a lot, Dr. Sahin, for covering the pubertal and reproductive areas, which are very important. So if we just go into, we already discussed how to monitor in that regards. And now if we can just go into the different aspects. So if you want to intervene in terms of growth, if a girl is not growing well by around 4 to 5 years of age, you have to start thinking of growth hormone in that regards. Puberty, as discussed, around 12 years of age, 13 years of age. If there is no pubertal development, if there is spontaneous development, wait and watch. The treatment as far as thyroid, of course, is you have to give thyroxine and gluten-free diet. HbA1c, diabetes, rare, but you can have after puberty, so you can think of metformin in that situation. Hearing, very important. Don't miss on hearing because this can affect the school performance. And eye, of course, ophthalmology review, cardiac, very, very important. So monitor for echo and functional MRI. Think of indications for antihypertensives, beta blockers, ACE inhibitors, consideration with regards to surgery. Very importantly, renal ultrasound very frequently, hip examination, spine X-ray, and bone density. So this is a very, very complicated condition which requires careful evaluation in the long term, and we all need to be wary about and be ready for in that perspective. So I think what we'll do now is that we'll take a few questions if they are there, and then we'll start working with regards to, again, the cases which are going to be the crux in that regard. So we'll see if there are any particular questions which are there. So Dr. Rajesh Joshi is asking, why do you do AMH and inhibin before pubertal induction? Is FSH not enough? So Dr. Rajesh, if you really have an unequivocal, very high FSH level, it is no confusion. If you have a borderline FSH, you want to make sure that AMH and inhibin, I won't say would be that much relevant. AMH will be a better marker in that regards. If your FSH is high, your AMH has to be low because AMH has got a higher sensitivity with regards to that as compared to inhibin. Which transdermal forms are available? Currently, the one which are available in our country are more the gel preparation, the Easter dot, which is available. It's not very easy to procure the various forms of patches. So it's more like the gel preparation which are there. But otherwise, unfortunately, we are really stuck up with more of a oral preparations like estradiol in that situation. So I think we'll now move forward to the next aspect, which will basically cover the lot aspects with regards to the overall discussion of cases, which will really cover the entirety of what we've discussed till now. So I'll invite Dr. Pratik to start off with this case.
Thank you, sir. So these, I will be starting with the cases. Now, this case was discussed initially. It's a 10-year-old girl with growth failure who is short. TSH was raised and she was started on Thyronorm based on this TSH, but there was no response in the height velocity. So what could be the issue here? So this was actually a Turner syndrome, who had concomitant hypothyroidism.
So this basically gives a message that every short girl, keep considering Turner syndrome, even if you have made a diagnosis. Somebody diagnoses thyroid. See, normally if somebody is very short, TSH should have been more than 100. So that's what we are seeing. So it's a borderline TSH, borderline TTG. Always keep on thinking that Turners may be there. You start thyroxine, of course, but you may consider Turners later on in that situation.
A 12-year-old girl, this was also discussed, who was short, no pubertal, and all brachymetacarpia were being high FSH, advised GH, did not take GH, presented after 4 years with abdominal lump, and this was a mixed Y cell line, which should have been caught on karyotyping.
So again, the big message, FSH is good if you want to make a diagnosis, but it is not enough. You have to do a karyotype to really make a good diagnosis and exclude the possibility of a Y cell line.
Now, a 32-year-old pregnant lady underwent a non-invasive prenatal testing, which was suspicious of Turner's. However, there were no changes on the ultrasound.
So what changes are you looking for?
So I would expect a cystic hygroma, short femur, renal abnormalities, and lymphatic obstruction.
So what will you do in this case? There is no clinical features on ultrasound, but just an NIPT was done. So what do you do?
So this has to be confirmed with the CVS or amniocentesis according to the gestational age.
So this is very, very important, as Pratik already said, that NIPT is unreliable. So we do not rely on NIPT just for the diagnosis. So you have to confirm it first and then go from there.
A 36-year-old pregnant lady underwent amniocentesis, karyotype showing Mosaicism, 46XX and XY.
So what do you think? This is a very, very common finding which is there. So could this be a DSD? Could this be a Turner syndrome? What do you think?
So first of all, we need to see the pretest probability issues. This could be anything. So we have to look in further. So there was no ultrasound features of Turner syndrome, making the pretest probability very low.
So what do you think is the most common postnatal phenotype, karyotype for these individuals?
So mostly it is a 46XY, that is a male, and the X is probably a maternal contamination.
So when you're taking the sample, there could be a possibility that the the cells may have mixed. So therefore, you should not rely upon this. And as discussed by Pratik, it's always very, very important to have a proper postnatal karyotype in this situation. So any antenatal karyotype which is suggestive of a sex chromosome aneuploidy, you should always go ahead with one of all. First will be to look at the clinical features of the diagnosis and then a postnatal karyotype. So most XXXY actually antenatal will turn out to be a normal boy with a XY karyotype. This is an important message from there.
A 35-year-old pregnant lady underwent amniocentesis showing a mosaicism 46X and X45X. There was cystic hygroma.
So what do you think here, Pratik?
So here we have a high pretest probability, and there is a karyotype is also showing. So this, as we discussed, all prenatal testing needs to be confirmed with the postnatal testing. And since there's high probability, this came out to be a mosaicism of Turner.
If you're doing a karyotype on the basis of a particular abnormality that you're seeing on ultrasound, the chance is much higher. Otherwise, don't rely just on karyotype.
11-year-old girl with short stature with coarctation of aorta. This was corrected at 1 year of age, and now she presents with short stature and weight and classical features of webbing of neck.
So the error here is that she should actually, just because she had a coarctation of aorta, we have to have at that point of time thought of a possibility of Turner syndrome. Often they are missed. Luckily, she came within a year, but she had all the features of Turner syndrome. So do not miss. If you have any of these typical findings, a cardiac defect, which is the most specific defect of cardiac with regards to Turner syndrome?
Bicuspid aorta.
That's the most common.
That's common.
So which is the most specific?
Transverse aorta.
So which has got the highest odds ratio? So if no, it's the partial anomalous pulmonary venous return. So if you have a PAPVR, the chances of a girl having Turner is huge, but that's a rare situation. So of course you have to look at that. So if VSD is very common, the chance of Turner will be very less. Similarly, PAPVR will be a very high likelihood, but it is so rare in the general population that if you have PAPVR, think of Turner's, very important. Coarctation is definitely, left-sided defects are very, very important. So this should have been diagnosed at the right time.
A 16-year-old girl with primary amenorrhea. Now here we have a good height, no breast development, but pubic hair development is there. Somebody did an FSH which was more than 100, and a karyotype showed a deletion post the 20Q level.
So is this Turner syndrome?
So as I discussed earlier, anything beyond 20Q does not really call Turner syndrome. It is primarily an ovarian insufficiency.
So it's basically in the FMR region. So if you had not done the karyotype, you might just have labeled as a PO.
Yes.
So this is not Turner's. Why is it important? Because you don't need to do a cardiac evaluation here. You don't need to look at hearing here. It's just that you have got a distal defect, which is not going to have a significant impact.
A 14-day-old child with atypical genitalia, there was scrotal fusion and asymmetrical genitalia. Ultrasound showed Mullane structures, and karyotype showed the mosaicism of 45X and XY.
So do you think this is Turner's?
So of course not, because there is DSD, and we cannot call the DSD as Turner syndrome.
So this is a typical XY DSD pretty much. There is gonads are, you've not mentioned about the gonad, but anyway, so this is more like a, as discussed in the last time, more like a classically what we said mixed gonadogenesis, that sort of picture. So
asymmetrical is there.
So if there is a atypical genitalia, never label them as Turner. So Turner is a phenotypic female with the clinical features with one intact X chromosome and deletion of part or entire of the remaining X chromosome.
A 10-year-old girl with development delay with ADHD, dysmorphisms and syndactyly. The height is extremely short. And is this Turner syndrome is the question. So as we can see, this is probably a ring chromosome because there's dysmorphism and syndactyly. And this is probably involved the XIST region. And this is because of that problem.
So again, if you have got XIST involvement, they will have short stature, but they will have many more things. Why do they have all these problems, Nami?
Because of
other which has to be inactivated has not been inactivated. So there will be lot of genes.
So a lot of dual expression of these genes, and that's why you have there. So this is traditionally not really Turner syndrome, but of course, because some other genes are also deleted, you will have a problem there. So this is a classical ring chromosome.
A 10-year-old girl with short stature, height is short, with brachymetacarpia, webbing, and karyotype showing marker syndrome, a marker chromosome.
So what will you do here, Sayan?
So, as the child has a marker syndrome, we have to go in for a fish analysis to determine X or Y.
Yeah, because we don't know in the marker chromosome whether it's a X or Y. So you do a simple fish, and that will tell you which way to go forward.
12-year-old girl with Turner syndrome, diagnosed at 8 years of age. Now short stature is there. Child is on growth hormone. It showed increased growth velocity, but then presented with clitoromegaly and hirsutism.
So what do you think, Pratik, is happening here?
So this is probably the expression of the Y cell line, which has not been detected earlier. So probably the next step is to get a fish and which showed a Y cell line, and the best thing to do a prophylactic gonadectomy.
So again, if you have clitoromegaly and hirsutism happening at this age in Turner's, or we talked about in DSD, we said that if you have gynecomastia in a male and virilization in a female, you're dealing with a ovarian or a testicular tissue. The same thing is happening here. There is some component of testicular tissue which is causing this virilization. So Y cell line should be done, and gonadectomy, as you said, was the right thing.
A 9-year-old girl with Turner syndrome who is short, with poor growth velocity, somebody did a peak GH stimulation and it showed normal. So what was the issue here?
Do you think this girl will benefit from GH?
No, sir, it is not actually GH deficiency because the estrogen response is not present, which could lead.
So, testing.
So this testing is not required because this is more like a pharmacological. So your decision for treatment is not based upon your growth hormone testing. It is oxological. So her height is definitely way below the 5th percentile. She merits. Don't do a GH testing. It's not going to help you out in that regards.
Now this girl was started on growth hormone. The growth velocity was poor at around 3 centimeters per year, despite good adherence and ruling out all the other factors. So what turned out to be the question was that the girl wasn't just a physiological replacement dose, and she should have been on much higher, almost double the dose which she was getting.
This is something which is very important. So if you want to treat it properly. There's no point in actually giving a small dose. You're wasting a lot of money and not getting out of any benefit. So best would be to start in a proper dose of around 45 to 50, which will increase the growth.
Now this same girl, after 3 years, showed initial good response. Then again, there was growth velocity was poor. We looked at the other features and she said that she had abdominal pain, and on evaluation there was anemia.
So what do you think, Pratik?
So the various causes of decreased growth can be hypothyroidism, celiac disease, and IBD. And it turned out that this girl had a TTG of more than 220. This is probably
And
celiac.
remember, her initial TTG was negative. So as Naveen had said, you have to follow up also. It may develop over time. So celiac will be a big indication in that regards.
She started gluten-free and she showed improved growth.
So always consider your general endocrinology very importantly. Just because she is Turner's, don't forget that she can have celiac, she can have hypothyroidism. All those things can be there.
A 12-year-old girl with Turner syndrome who was short and showing no breast development was then concerned about growth. So what would be the plan here?
So this is a classical presentation. As Sayan was saying that they come to us so late, what to do. Now, if you want to wait for 4 years for growth hormone, that will be 16 years. So the options here, Pratik,
So
will be?
we can either give a non-anatomizable androgen, which is oxandrolone, or delay the pubertal induction till up to 14 years.
So these will be the two options.
A 12-year-old girl with Turner syndrome on growth hormone for 4 years, and pubertal induction was done, and she reached breast staging. The plan was whether to do pubertal induction or not, and she reached breast staging 2.
So what do you think?
So as we discussed here, we can wait and watch because 1/3 almost progress.
So this is basically a spontaneous development which has happened. So around 5% can have a spontaneous development. You found that the FSH is not really high, AMH is normal. So in this situation, you can just follow up in that situation.
A 15-year-old girl with the complaints of primary amenorrhea, height is 132 centimeters, and with the webbing of neck, and FSS is 120, very high, and with the karyotype of 45x. Now, this girl was started on an ethanol dose of 20 microgram per day.
So, Sayan, do you agree with this?
So, it should be started from around 2 micrograms per day.
So first, ethynyl estradiol is not something which we recommend. Ideally, go by the subcutaneous. If not available, go by valerate. That is better. And then you start at 10% of the dose. So this is huge. So she will have a huge problem which will happen because of the sudden estradiol surge which is there. So always start at a low dose and gradually build up from that situation.
And she was then started on a lower dose. A 14-year-old girl with Turner syndrome, diagnosed at 8 years of age, and was on growth hormone for 4 years and hormone replacement for 2.5 years. And this girl was on estradiol valerate 2 mg high doses. There was increased breast staging and endometrial thickness was also good. So somebody did an FSH which showed 32 and was in a dilemma what to do now.
So Naveen, what do you think? Why is her FSH high? She is Turner, she is on estrogen. You treat hypothyroidism, the TSH becomes normal. But why is the FSH high here? FSH is 32. Despite treatment, do you increase the dose sign?
So there is no role for monitoring of FSH during therapy. It
Why?
will remain high for a long time.
Why?
Inhibin is the...
So basically, this is an important physiological point which we did not raise, but it has come up on the case. As Pratik is saying very nicely, that the major regulator of FSH is not estrogen, it's inhibin. So you have given estrogen, but you're not giving inhibin. So your FSH will remain high. So there is no role of monitoring FSH in the treatment of either Turner's or any form of, like, if you talk about male hypogonadism, second primary hypogonadism, we talk about POI, no need of doing FSH because inhibin B you're not giving. So again, somebody did FSH, which is, you don't need to increase the dose from there. She's improving clinically.
An 18-year-old girl with Turner syndrome was concerned about her breast size. She was diagnosed at 13 years of age, on growth hormone for 2 years, and had reached high dose estradiol. But progesterone was somehow started after 1 year of giving estradiol.
So what happened, Pratik? Why was the breast development not there?
So as we know, progesterone is required for the terminal development, and if we give it earlier, there's actually reduction in the breast development and uterine size. So this should have started after 2 years of giving estradiol or estradiol.
So simple thing to remember is that estrogen is causing proliferation, progesterone is causing maturation. If you mature early, as in precocious puberty, you are short. If you give progesterone early, your breast will be short, your uterus will be short. So at least 2 years, 2.5 years should be there. Some people say wait till the periods happen. Some people say the ET more than 5. I'll say minimum 2.5 years is required. No urgency, because otherwise the shape of the breast, the size of the breast, the size of the uterus will be affected. Don't give progesterone early.
A 13-year-old girl with Turner syndrome was diagnosed at 7 years of age on growth hormone and estradiol therapy, now concerned of fertility preservation. So as we know, the fertility issues depend on the age of the child and the ovarian reserve. So to assess ovarian reserve, an AMH was done and which was showing normal. So above 2 ng, more than 12 years, oocyte freezing is the best option.
So I think what you need to remember is that the ovarian freezing is an experimental therapy. There is no proven report of pregnancy after ovarian freezing. Oocyte freezing is a commonly done thing which happens in IVF. So if you really want to do something, do a oocyte freezing. So that's why we said 12 years, you wait till 12 years. If your AMH is basically below 2, less than 12, then you don't have any option. You can't wait for the oocyte freezing. Because for oocyte, you have to actually stimulate. You have to induce the ovaries, and then you have to do it. It is a complicated process. So young girls, of course, you can't stimulate. But if you have a young girl whose AMH is low, then you can say, okay, let's try a desperate measure of a complete ovarian freezing. And then we will try to take off the oocytes later. After 12 years of age, you can do a oocyte retrieval, although it's difficult, but can be done. And if your AMH is low, of course, it's not possible because you don't have any oocytes. If AMH is there, like in this case, you can go for oocyte freezing. But all of these are experimental, I would say. So you have to discuss with the family, refer to a proper ART specialist who deals with this. And of course, the issues of long-term pregnancy, coarctation, and all those things become relevant.
So the next case of the 17-year-old girl with Turner syndrome who received growth hormone and hormone replacement developed sudden abdominal pain. And unfortunately, when she presented in the OPD, in the emergency, she was in shock. So this was clearly a case of aortic dissection. What was missed was a coarctation which had not been diagnosed earlier, and then she underwent coarctation surgery.
So this is a major issue. This is a big risk factor, major cause of death. So keep monitoring. And cardiac MRI is now emerging as an important modality which has to be looked into.
A 24-year-old lady with Turner syndrome was well managed during the pubertal period. Oocyte donation and ART was done for her, and she was now pregnant. But unfortunately, she too developed abdominal pain. This was an aortic dissection. What was missed was an uncontrolled hypertension in this case, which led to this dissection.
So never ever advise a pregnancy or an ART before you have had a proper cardiac clearance, because that could be a big issue. And if there is uncontrolled hypertension, coarctation surgery, there's a huge risk which may happen subsequently.
A 13-year-old girl with Turner syndrome diagnosed at 8 years of age received growth hormone for 4 years and non-estradiol therapy. Now she comes with worsening of school performance.
So what all will you think, Naveen?
Hypothyroidism could be a possibility. Hearing defect could be a possibility. Eye abnormality could be a possibility.
So you have to look at all evaluation.
And in this girl, there was a hearing defect, and a myringotomy was done after that.
So often at this age, you're more of a conductive sort of a thing. So effusions, which will be more common. So that will help you out. So I think thanks a lot, Pratik, for discussing this whole topic very well with the cases. So what we'll do now is just to go through the basic things. So you need to understand that the diagnosis of Turner syndrome requires a combination of clinical parameters and karyotype, and a minimum 30 cell karyotype is what is recommended. Look for growth, cardiac and ovarian issues. Very importantly, only phenotypic female with loss of partial and complete X is required. There is a significant genotype-phenotype correlation. If there is classical form, more severe, mosaic milder. If you have a Q form, more of hypothyroidism. P deletion, if you have a P deletion, of course, you will have more of a growth failure. Distal Q deletion is more of the presentation with the ovarian failure. If there is a ring chromosome, you have to think about mental retardation and psychosocial issues, and marker chromosome, the risk of malignancy becomes important, and manage growth, cardiac, puberty, and all those things in an appropriate fashion. And so I think we'll thank all of you for patient hearing, and thank all the people who have been part of it. Dr. Pratik, Dr. Naveen, Dr. Sayan, and Nikhil, who has been part of our back team, who has been working a lot, putting up all these questions which are there. You can have a look at our website, learningneurobrosociety.in, and the books also which are available. So we'll take a few questions which are there at this point of time, and try to address them in that regards. We'll hope to put up this basically talk over the next week or so with regards to the different parts of the presentation. So what we'll do is now is that we'll basically take up a few questions which are there. So Dr. Patil is asking, what is the type of estrogen in transdermal estradiol? So it's basically the 17 beta which is there. So it's the actual estrogen which is there. So this is the form. Dr. Patil is also asking, which is the same question which has come up. So I think basically it's the 17 beta estradiol which is there. So transdermal estrogen is something which is desirable, because that is going to help you with regards to lower risk of decreasing IGF-1, hypertension, as well as the impact on thrombosis in that regard. So if you use it appropriately, there will be an improvement on that. So if there are no other questions, we'll close the session, and we'll plan to do some other sessions subsequently and hope to meet you. The links will be available on our website. The webinar, the previous webinars, you can have a look at that point of time. Thank you.